others. Thank you so much for being with us. It's been an exciting day here at the Right Care Initiative. Excitement on the last day before a session begins is not always the greatest thing, but what an amazing team coming together. Joe, I know that you're on duty at Travis Air Force Base right now. I think many of you are at your hospitals working, so we certainly understand if you need to pivot away and help with patient needs. I want to welcome you to the 307th gathering of the Right Care Initiative. We previously did in-person meetings, and now that we're gathering by Zoom, we can bring people together from all over the state, all over the country. I want to assure you that the slides and the video will be available quickly. If people have operations needs, please ask those of albert1030@berkeley.edu rather than chatting those to the whole group. Our next university best practices after our brief 1-month sabbatical from between our semesters of the university best practices will be Monday, August 8th. And we would be thrilled to have you back with us then. So I see that we have some of our colleagues from the Stroke Awareness Foundation joining us. I believe many of us here together are basically very passionate about this because of things that have happened in our own experiences. And I want to encourage people to share their thoughts in the discussion. I would like to discourage people from chatting very much so that we can focus on what people are saying as opposed to doing a side communication. I've just seen some unusual chatting where, Jenny, if you can change the settings so that I wouldn't see that sort of thing on my screen, that would be helpful. But for now, I would just request that people stop chatting to the whole group. So I want to thank our amazing collaborative of people that have come over together over the last 15 years. We have Katrina Taylor now joining us from the California Department of Public Health. She's still getting her audio. Welcome, Katrina Taylor, our fearless leader at the state of California. And just in the nick of time, we've got amazing experts coming together. I want to thank our supporters from our mothership of UC Berkeley School of Public Health, the Center for Health Outcomes and Innovation Research, the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, and our various UC partners, including the University of California, San Francisco, University of California, Los Angeles, Stanford, University of Southern California. We have Bob Kaplan joining us here, former Chief Science Officer for the Agency for Healthcare Research and Quality. What a wonderful gathering today. We have so appreciative of the support that we receive from the Stroke Awareness Foundation, from the Tennis Getter Family Foundation, our biopharmaceutical partners, and the Health Trust of Santa Clara County. And with that, I'll just say next slide, please. Most of you know me. I have been passionate about clinical quality improvement since I was about 15 years old, and I witnessed the treatment that my mother received when she was dying of a stroke, and I have devoted my career to improving clinical quality in this area, including working on legislation at the state of California on clinical quality improvement. Next slide, please. So I just want to create a little bit of context based on the new wonderful database of the Centers for Disease Control, which allows us to compare at very detailed levels more data on deaths than we previously had easy access to. So we're very interested in this group of patients or consumers who don't know that they're about to be patients, who are in those active parenting years and who are vulnerable to death from cardiovascular disease much earlier than they have any notion of. Our public health campaigns are very much around screening for cancers, breast cancer, cervical cancer. You'll see here, actually already in the 35 to 44 year time frame, kill fewer people than the cardiovascular conditions that we're working on here together as a group. Hypertensive diseases, ischemic heart diseases, cerebrovascular diseases, together already kill more people in the 35 to 44 year age range than the cancers that are standardly screened for. So we really want to change that dynamic to raise awareness and do earlier screening and intervention. It's even worse for men, of course. They have much earlier cardiovascular disease. And with our partners here on the Zoom together, we're very much hoping to change this dynamic to raise awareness of these early deaths from cardiovascular disease that we believe many of which can be prevented. Next slide, please. So we synthesize the best practices, the best available evidence, and we try to spread them to get them adopted. Next slide, please. With that, I want to say that we have a very exciting agenda today with people gathering from all over the country. Even several other countries are joining us today. It's the power of Zoom that we can now collaborate across all of our regions of California. We used to meet in person, and now we're able to bring our Los Angeles group, our San Diego group, our Silicon Valley group, and our Sacramento group together, and they're all here with us today. We are going to first hear from Nirali Vora, who will be introducing the amazing UCLA neurologist, Dr. Jeff Saver, and then we'll be going for an hour on innovations that are happening in the stroke space that we can all benefit from. And we will then switch to one of the reasons people are having early strokes and early heart attacks. We'll hear from the wonderful vice president of the Family Heart Foundation on familial hypercholesterolemia and Lp(a). And then we'll have a group of experts from the University of California, San Francisco, talking about some of the underlying drivers of why are we having these early heart attacks and strokes. Next slide, please. So Dr. Nirali Vora is one of our fearless leaders from the Santa Clara Valley region. She is a stroke neurologist that trains the residents at Stanford, and she works globally with her knowledge of neurology. And with that, I think, Nirali, we should turn it over to you to kick off the meeting on stroke. I'm sorry we don't have time to play that wonderful video that we did in our last stroke meeting. And with that, I'll just say thank you so much for facilitating the stroke portion of our meeting, which is the first hour. And welcome to the Stroke Awareness Foundation. Thank you for being with us.
Yes, thank you to all of you for being here on a Tuesday afternoon or wherever you might be, actually. It's my great pleasure, actually, and honor to really introduce Dr. Saver. Dr. Saver is the professor of neurology at UCLA, where he directs the UCLA Comprehensive Stroke Center and is also the senior vice chair for research. And you can read his bio. He has run hundreds and thousands of trials at this point, as well as been very much involved in advancing our field and has really been involved in innovations on the whole spectrum of stroke. You know, many of us will focus on acute stroke care, interventions, prevention, rehabilitation. Dr. Saver's done it all, as well as really thinking about the pre-hospital delays. And this is something that, personally, I've had the pleasure of meeting Dr. Saver when I was a resident. And, every time I pick his brain, it's sort of, I don't know if you remember this, Dr. Saver, you always, had already done some research in that. And so I really appreciated seeing someone who really thought about how do we translate all these great innovations that we have? How do we get patients from the field to actually access the system of care that is advancing constantly? And today I'm really excited that he's going to share some of the further advances we've made in using technology and leveraging it to think about reducing pre-hospital delays and early detection. So Dr. Saver, thank you for being here. And I know you're busy on service, and we really appreciate your time today.
Thank you so much, Nirali. It's so wonderful always to work with you. I learn from you and as much as you learn from me. And I'm very excited to be back with the Right Care Initiative and this important undertaking to give a bit of a future-looking talk on where I think we're headed with improving stroke detection in the pre-hospital setting. And let me share my screen. Put my slides up. Okay, so this talk is going to be about innovative technologies to accelerate stroke detection and hospital arrival. And here are my disclosures, and let me note that I am on founding stock option committees for a couple of companies that are working this space. So please take that into account as I talk about I have interest in this interesting area. And today I'm going to focus on hyperacute diagnosis of stroke, the presence, maybe type of stroke, by wearable monitors for patients, and in the ambulance by stroke helmets with paramedics or EMT delivered. And the reason for this technology is we all know that stroke is a time urgent emergency. In a typical large artery, middle cerebral artery ischemic stroke, every minute that goes by without restoring blood flow, 2 million nerve cells are lost. Every 4 minutes that goes by without treatment, 1 fewer out of 100 patients benefits from treatment. So we want patients to come in as quickly as possible. And we educate the public to be aware of the FAST and BFAST and other symptoms, and to not only be ready to call themselves, but also to empower on-scene witnesses to call about somebody else, because often that's what has to happen for the call to get through. And here in LA, where we have 150 languages spoken in the home, we have to make sure that this public messaging reaches patients and caregivers in the language that they are fluent. However, 20 to 25% of ischemic strokes, 1 in 4 to 1 in 5, occur when the patient wakes up, is when they're first observed, but they could have started hours earlier when the patient went to sleep or in the middle of the sleep period. So they're actually several hours old by the time the patient might notice it. Or they are unwitnessed, meaning the patient's not able to tell us when it started, and nobody was with them to tell us when it started, even though they were awake. The patient might be unable to speak, aphasic. The patient may have neglect and be unaware they have a deficit, and or the patient might be found down and not able to report about the time of onset. So public education to call about the onset of symptoms works, not as well as we would like, but at least has the potential to work for the 80 to 85% of people who have onset in waking in a witnessed setting, but it doesn't have even the potential to work for this large group of patients. So what can we do? And I think the useful model herald of where we're heading is what happens in the casinos in Las Vegas. Because in the casinos, they have these cameras studded all over the ceiling, and security is constantly monitoring to pick up card counters and the like. And in addition, the security is told that if somebody stops playing because they are sick or injured, they should immediately call 911. They don't want to talk to them about how they're feeling and should we call, because the longer that any interaction goes on, the fewer people are playing the machines. Everyone turns to watch what's going on. So they're told to call 911 right away. And as a result, I believe that Las Vegas has the shortest onset to door times for stroke in the country. In the old days, when you had the physical slot machines, it might be different if you had a right-sided weakness or a left-sided weakness when people would realize that you weren't playing. But now with the video, we can see it for everybody. So this speedy recognition of stroke occurs because there's ubiquitous monitoring in the casino, and there's human intelligence observing the monitoring, ready to respond. But we live in an age where, for good or for ill, ubiquitous monitoring and ambient intelligence is becoming the norm wherever we are. We have home cameras and voice assistants, home health robots, smartphones, the computerized vision, all of which have the potential to be able to recognize that a patient is having stroke symptoms, even when the patient can't recognize it themselves. And the real first, I think, practical application of this is in the Apple Watch, which is shown down here, which has automated fall detection. And if someone falls and does not tell the watch to stop, the watch will call the 911 EMS services automatically. And we've had stroke patients who had a fall related to the onset of their stroke, in whom the watch is the observer that called 911 and brought the patients to us in a timely fashion. And you have to be wearing the watch to have it work, and some people don't like to. It has to spend time recharging batteries, and some people have trouble, especially older folks at risk for stroke, in maintaining the watch in ready position. So it is a good start, but we need additional ways. And for looking at fall detection, another approach is by video surveillance, as we saw in the Vegas casinos, but with artificial intelligence, machine learning vision to recognize when someone has fallen, potentially from a stroke. And here is an example of a camera system that detects the different types of falls. And I didn't realize this, but there's now a classification of falls: stumbling, slipping, fainting, falling on a rising from a chair, falling off a height, and purposely jumping and falling. And each of these has a different visual signature that the artificial intelligence networks can recognize. And this means that any scene that's surveyed by a CCTV camera can become a place where stroke recognition can occur automatically much more quickly. Plus, any computer that's looking at us, or smartphones, or right now you're seeing me on video and my computer's seeing me on video, can also recognize if this type of change takes place. We recently reviewed the range of devices and approaches, and it really is amazing the advance in this technology, much of which is in the consumer space first and then migrating to the health space. There are accelerometers, gyroscopes, and magnetometers that detect movement, normal and abnormal. There's touch screens and keyboard touch sensors that determine how well people are executing motor movements, haptic sensors that let people determine if they can feel what the phone is doing, for example, computer vision, as we talked about, and audio with our home voice assistants. And these have form factors of being smartphone, smartwatches and fitness bands, and smart speakers voice assistants. Those are widely used, but also we're beginning to see smart clothing and coming out in Japan, and we're beginning to see use of home health robots, closed circuit television everywhere, as I mentioned, and in our computers. So besides falling, what else can these approaches do? Another major symptom of acute stroke is sudden facial weakness. You know, we have the face arm speech test, face weakness, arm drift, and speech difficulty. It's time to call 911. And there are a variety of programs that have digitized hundreds of faces at rest and moving, and determines what's the range of a normal symmetric expression and what's the range of one side of the face not moving well. And you have to be able to do this when people are looking to one side or looking to another. And the artificial intelligence can process that. And you also ideally could distinguish when there was weakness of just the lower portion of the face, which is what tends to happen with stroke, versus weakness of the entire side of the face, which is more often due to a peripheral nerve inflammation. And great progress is being made with these. I think that the ability to detect facial weakness is nearly as good now as the ability to detect falls by these artificial vision systems. Now, another thing that many of us have in the home is the voice assistants like Alexa, which are listening to us all the time and can detect alteration in our speech, slurred speech, or aphasic speech that could signal the onset of a stroke. And here's a case that we had a couple of years ago, a 47-year-old man who had set his usual morning alarm on Alexa, and the alarm went off, and he said, Alexa, turn off the alarm. And Alexa said, I'm sorry, I did not understand what you said. And he said, Alexa, turn off the alarm. And eventually, the third time, Alexa responded, being a physician and a male who doesn't want to admit weaknesses. Instead of responding to this, he stayed in bed and sent texts on his phone and read text. So we know that his language areas were functioning well. He had no trouble with reading and writing or texting. But 15 minutes later, this snooze on Alexa went off again, and he had to turn it off verbally, speech a little better, but still slurred. He went to the bathroom and noticed that he had a slight right facial weakness. And he headed to the emergency department. By the time he got here, he was completely back to normal. But when we did his brain imaging, we found this area of low blood flow in Broca's area on the left front of the brain, speech production area, and this area of tiny injury in that area. This was a baby Broca, which can produce cortical dysarthria, slurred speech from a very focal region, just as the motor fibers leave the speech area. There's a famous syndrome in neurology of people who can't read but can write, and that's called alexia without agraphia. But this patient had what we termed a similar sounding syndrome of alexia without agraphia, or alexia without atextia, which represents the types of syndromes that we are seeing in our new technologically savvy world. Now, let me turn to clothing with wearable sensors. And California is actually one of the leading places in the country for this, with the different nano institutes, engineering institutes on UC campuses and other campuses in the state. And here, rather than just yarn or steel, there's functional fibers that are made with tiny little electrical elements in them that, when you twist the fiber, will set off a signal, and it can be used to weave clothing that can then detect different types of stimuli. And as a result, we are seeing the development of smart socks, smart vests, and smart sleeves, smart insoles. We have a research study here with the UCLA Nano Institute looking at smart insoles for stroke detection. And you can see that this material can sense where stepping is occurring, and if stepping is occurring in a normal fashion or an abnormal fashion, if one leg is dragging, if one leg is hitting the outside of the heel rather than the center of the heel, and can recognize abnormal gait. And smart clothing can determine how the trunk is moving, and I think most importantly for stroke, how the arms are moving. And if somebody develops weakness on one side, be able to tell that, including in sleep. If somebody becomes hemiparetic while asleep, their normal movements during sleep will be occurring only on one side. So this is a way that we could determine right soon after it happens, stroke onset in sleep. And here's how this technology is being developed by artificial intelligence. We have to map normal human environment interactions in how people walk, how people squat, how people twist, and the signature of those movements that shows up in the heel, and then be able to recognize when people are having abnormal movements that don't fit with the normal range of human activity and may represent a stroke occurring. So those are, I think, the exciting, a little bit more far future developments that are occurring to help patients detect the stroke when they can't themselves be able to detect it. Now let's turn to the second section of my talk, which is how we, this type or related technology is beginning to help paramedics and EMTs to recognize stroke in ambulances after the 911 system has been activated, either by a patient, an on-scene witness, or an automated artificial intelligence system. And as you know, we have a 4-tier system for acute stroke regional systems of care, with the first general level are the acute stroke ready hospitals and primary stroke centers that can give the clot dissolving medicine TPA very well. And the second tier are the thrombectomy stroke centers and comprehensive stroke centers that also can do clot removal by catheter techniques and more advanced neurosurgery. And that means we have centers that have treatments that work really well for smaller occlusions. IV dissolving medicines are very good at chemically lysing small clots, but they don't work very well for the big clots at the base of the brain that have very large clot burden. On the other hand, catheter techniques, thrombectomies, are very good for pulling out mechanically the large clot burdens at the base of the brain, but have trouble reaching the smaller, medium-sized arteries more superficially. So if you're having a large artery stroke, it would be good for you to go straight to a center that does the thrombectomy technique, as long as that center is not too much further away. You should bypass a primary stroke center and get to the more definitive treatment at the comprehensive stroke center. On the other hand, if you're having a more medium or smaller size stroke, then you want to get to the nearest primary stroke center as fast as possible, because thrombolysis is going to be the treatment that you need, and the sooner you get it, the better. And that means we want to start sorting patients in the ambulance, not just who has a stroke and who doesn't have a stroke, but also details about the type of stroke occurring to determine where patients should go. And there are a variety of techniques that have been developed. There are 2 main tools that have been developed for paramedics to use. There are simple stroke recognition scales to tell whether a patient's deficits are due to stroke or due to a mimic like migraine or a benign positional vertigo or something else. And then more recently, those are used to say you should bring a patient to a stroke center. More recently, in order to determine if patients have the large vessel blockages or the small vessel blockages, we have stroke severity instruments being developed. And the more severe your stroke, the more likely it is to be occurring in the large vessels affecting more of the brain. And so a wide range of these are out there. We developed the Los Angeles Motor Scale, the LAMS. There's been in Europe, probably the leading one is the RACE. And if you look at these, they kind of illustrate the range of these for paramedics. The Los Angeles Motor Scale just asks them to rate, is the face drooping, is the arm drifting down, is there grip strength, and how much? And you get a 0 to 5 point scale. And if it's 4 or higher, it's likely to be a large vessel occlusion. The RACE is a more complicated 7-level, 7-item, which in addition to motor weakness looks for gaze deviation, language abnormality, and hemispatial neglect or abnormality. If you, in a variety of studies that have been done of these and many other instruments that have been developed, they all perform fairly well. They generally perform about the same, none of them perform very well. They get it right maybe 75% of the time that a patient is having a large vessel occlusion versus a small vessel occlusion. But a quarter of the time they get it wrong, and a small vessel patient will go to a large vessel hospital and have spent longer before getting the drug they need, or a large vessels patient will go to a small vessel hospital first and take longer to get the thrombectomy that they need. So here in Los Angeles County, we are using the Los Angeles Motor Scale, and this is in a non-technical fashion, simple paramedic exam, to route patients in a two-tier system. We have now 50 designated stroke center hospitals, about 30 are primary stroke centers, and about 20 are thrombectomy or comprehensive stroke centers. And in 2018, the EMS agency began saying if you had a Los Angeles Motor Scale score of 4 or higher, suggesting a large vessel occlusion, and a comprehensive stroke center was within 30 minutes of where the ambulance was, that ambulance should go straight to the comprehensive stroke center and bypass primary stroke centers. Otherwise, if it's a more mild stroke, go to the nearest primary stroke center. And we reported that with the implementation of this system, there was a dramatic improvement in the number of patients with access to thrombectomy and the number of patients who actually received thrombectomy. Among ambulance transported patients, we went from 40% of patients having access within 30 minutes to 93%. And the actual rates of TPA administration did not change, actually went up a little bit when we put this system in place, but the rates of thrombectomy increased dramatically from 5% of ambulance transported patients getting thrombectomy to 13.5%. So 1 in 20 to 1 in 7 patients getting the clot withdrawal procedure once this change was made. And the rates of interfacility transfer of patients going first to a primary stroke center, being stabilized, and then needing to get to a comprehensive stroke center through burdensome second transfers went down from 3.5% to 1.1%. And interestingly, part of this improvement occurred not just because we were bypassing, but because once we told people we would be bypassing, many hospitals decided to become comprehensive stroke centers that had only been primary stroke centers before. In 2016, we only had 4 comprehensive stroke centers in the county. By 2018, we had 12, and as I mentioned, we now have 20. So when paramedics are trying to evaluate patients in the field, as I mentioned, with their current clinical scales, they only get it right about 3/4 of the time. And how can we improve upon that? First, let's remember the 3 distinctions that we would like them to be able to make. One is to tell that someone who's having neurologic symptoms is having a stroke versus having a mimic. And it's difficult for paramedics to do this. Only 2% of transports that paramedics do in the 911 system is for stroke. It's kind of a needle in a haystack. And if you look at all the patients with neurologic complaints pre-hospital, there's 10 with a non-stroke cause of the complaint for every 1 with it due to stroke. Seizures, fainting, migraines, and the like are more common. So we need tools that are both specific as well as sensitive to determine whether someone's having a stroke from a mimic. Another thing that we'd like to do is distinguish the patients who are having an ischemic blockage type of stroke from patients who are having a hemorrhage bleeding type of stroke. About 4 out of 5 strokes are due to blockages in blood vessels, depriving the brain of blood flow, and 1 out of 5 due to ruptures of blood vessels causing bleeding into the brain. And patients with bleeding into the brain have a high risk of needing neurosurgical procedures to take the blood out. And therefore, they need not only to go to stroke centers or even comprehensive stroke centers, they need to go to centers that have neurosurgery available 24 hours a day to do life-saving surgical intervention for intracerebral hemorrhage. So determining if someone has hemorrhagic versus ischemic stroke and routing them to neurosurgery centers is highly desirable. And then thirdly, as I mentioned, among the patients with ischemic stroke, we have patients who have large vessel occlusions, LVOs, and really big areas being affected, and patients who have medium or small vessel occlusions and have much smaller areas being affected. And we want the big occlusions to go to thrombectomy capable centers, and the MVOs and SVOs to go to the nearest primary stroke center. So we're asking our paramedics to do more and more, and they're doing pretty well, but they can't do this perfectly. How can we help them? One way that I know that you've heard about or will be hearing about, and so I'm only going to briefly mention it, is mobile stroke units. And these are vehicles in which an ambulance has a CT scanner aboard, has a neurologist, paramedic, nurse, and CT technologist. And here's our mobile stroke unit that UCLA operates throughout the county. And we go to the patient when a stroke call comes in, put them in the ambulance on the street, do the CT scan, and if it is ischemic stroke, start the TPA or tenecteplase right there and then, more quickly than can happen if they're brought to the hospital. And by doing a CAT scan in the ambulance, we can tell very well if it's a stroke or not a stroke, if it's a bleeding stroke or an ischemic stroke. And because we can do pictures of the artery, CT angiograms, we can also tell if it's a large vessel ischemic stroke or small or medium vessel. And looking further ahead, there's now a portable MRI scanner, a Hyperfine that's been developed, and the Georgetown and MUSC groups have been toying with putting the Hyperfine into an ambulance and having a mobile stroke unit that uses MR rather than CT. Not yet nearly as well worked out and operational as CT units, but an interesting potential additional way to go. But I'm not going to focus on these imaging techniques that require advanced imaging technology and technologists to run them in specialized ambulances. I'm going to today instead focus on what we can do to help paramedics in the many more standard ALS ambulances that are in systems. Any system's only going to have one or a handful of mobile stroke units, but hundreds of standard ambulances, and they'll be doing the bulk of the transport. So one thing that we can do is have the neurologist beam in to the regular ambulance and examine the patient by mobile video. As you know, neurologists now in emergency departments are frequently doing telestroke and examining patients at remote hospitals and making diagnoses and recommending the use of lytic therapies. But we can do the same thing in the ambulance, beam in and examine the patient, including while the ambulance is moving, and determine if the neurologist thinks the patient's having large vessel or small vessel stroke and route them accordingly. The challenge with this approach is that neurologists don't actually do all that much better than paramedics do in distinguishing large from small vessel stroke based on exam. They do a little bit better, but not that much better. So this only gives us a really minimal incremental addition. So that has led to a wave of emerging stroke helmet technologies. And these are developing different types of physical signals that can be emitted and then sensed by a device that would fit on the patient's head, headband or helmet or the like, that would probe the brain and without having sophisticated imaging, just say, there's something wrong here. This brain's having a stroke. This brain's having hemorrhage. This brain's having a large stroke. And there are many of these technologies in active development. We've worked both with Burl and Nova Signal, who are developing ultrasound for this approach. There's brainwave EEG techniques and new electromagnetic sensing techniques. There's infrared light projected into the brain and detected. My favorite named instrument is one that uses microwaves, developed in Australia, the Stroke Finder helmet. And then here in California at UCSF, Wade Smith has led the development of a device to detect brain vibrations, the Mind Ribbon device. And these are getting better and better, none yet in practice, but they are beginning to reach the point where I can imagine that in 2 to 5 years, they are performing well enough to be able to be used. Let's look at a couple of them in a little more detail. Here's a device that Wade has developed, and I will please disclose that I'm on the board for this device, but it's Wade's baby from UCSF, and it consists of this type of headband that has very sensitive gyroscopes within it, and it's able to tell the slight perturbations of our head that occur every time the heart beats, which sends a force of blood up to the head, and it bounces off and comes back down. And so our head is vibrating all the time. We really are bells. And and when the texture, the viscosity of the brain changes due to a stroke, that changes the tone of the bell, it changes the nature of the vibrations, and that's able to be detected with this device. And here's the signal from a normal individual. Here's the signal from an individual with a large ischemic stroke. And you can see that not only can this detect stroke versus normal individuals, it also looks very different from patients with small strokes and very different from patients with migraines. So this is a device that seems capable of distinguishing stroke from many mimics and large vessel stroke from small vessel stroke. And we now have test study underway in Michigan with paramedics there. About 250 patients have been studied to date where the paramedics are placing this device and getting recordings. It takes about 45 heartbeats for an adequate signal to be obtained. And we will, when we have a few hundred more patients, break the code, comparing it to the final diagnosis after imaging in the hospital, and determine if this becomes a simple, low-cost technology that paramedics can use to better identify and route stroke. And here is another technology. This is from Nova Signal, an ultrasound company that's actually started at UCLA 20 years ago, then went independently. And this is looking at transcranial Doppler ultrasound, where the sonar is sent through the thin temporal bones on the side of the head, detects the blood flow in the arteries, bounces back, and you can see the speed and shape of the flow in the brain arteries. Transcranial Doppler ultrasound is a mainstay of regular diagnosis in hospitals. It's been part of our diagnostic armamentarium for 40 years, but it's not been something that could be used in the ambulance in the past because it requires that a technologist knowledgeably with the probe, find where the artery is. Everyone has their arteries in a slightly different place, and everyone's temporal bones have variations in thicknesses in slightly different places. So it takes someone with expertise to spend the time slowly moving the probe around till they find a place where they can get a good signal and do a good readout. What Nova Signal has developed is a robotic artificial intelligence that can do this without human intervention. The robot slowly moves the sonar probe, and the artificial intelligence determines when it's getting good signal or bad signal from the artery and moves the probe to the right place to get the best signal. And you can see it's a bit cumbersome, but it's definitely something that could be put in place pretty easily on a patient in an ambulance for a quick readout. And this could tell us if the patient's having ischemic stroke, which would show reduced flow, and also large vessel ischemic stroke, also showing reduced flow in the large brain arteries. This one has not yet been taken out for field testing, but I know the company is working toward that in the next couple of years. So that is the glimpse I wanted to give you of where things are going in stroke detection by wearable technology for patients and by helmet technology to assist paramedics. And this has been a pretty far-looking talk, but I'd say that I really think that in 3 to 5 years, we will be using the helmet technology, and we're already using the iPhone, iWatch technology, and I think more of the wearable technology will also come. And here's a quote that I like. It's Amara's Law, and from one of the early leaders of the Institute for the Future, which Hattie, I just learned before this meeting, you used to work at the Institute for the Future back in the day, so this should be familiar to you. And that is about technology in general, that we tend to overestimate the effect of a technology in the short run. We think it's going to pay off very quickly, and often it does not. But we tend to underestimate the effect in the long run, that over 2, 5, 10 years, things change a lot more than we expect them to change. And I think that's what's going to happen in this space. So with that, I'll thank you for your attention, and I'll stop there. Take any questions.
Yes, I have a question, Dr. Saver, if I could. My name's Chuck Tennisketter. I'm the co-founder and chairman of the Stroke Awareness Foundation in Santa Clara County up here in Silicon Valley.
Yes, hi, Chuck. I know we've talked before. Great to see you.
We have. Just a couple of things. In our county, we have 10 primary stroke centers, and of which 3 are comprehensive, one of which is thrombectomy qualified or licensed. So we have a good spread of these hospitals in our county. We also have that redirection you talked about. I mean, you're hitting all the points very well. I really appreciate the things that you have put up here. And it has made, as you had mentioned, a major impact on redirection of stroke patients, hopefully whatever way possible, to the correct stroke center, and it's had an impact. The thing that we're working on right now that I'd like to just add to it is this mind rhythm device that Dr. Wade at UCSF, his group has put together, and it's being studied right now and trying to get the FDA approval for this. This to me is the beginning of a wonderful set of technologies that are being developed for the operators in the field to be more accurately determine whether it's a large vessel or a small vessel occlusion. And these things are, I like this one in particular, we all do, and we're hoping it comes through and satisfactorily, because it It costs $150. It's disposable, and it can be put in any ambulance in any place. Nothing's cumbersome about it. And I'm glad that you mentioned it in your talk. And I know it's down at the bottom of that list, but I wanted just to add that we think it's at the top of the list and has a lot of possibilities. If it doesn't, something along this line that's disposable and accurate is going to take its place in the not too distant future. So your comments are right on the money, and I appreciate them very much. And thank you for your talk.
Thank you. And it is the case that ambulances are different facilities of care than hospitals are. They have trouble with large capital expenses. And so machines that are high cost machines are difficult for governmental agencies to take on. They have to put them in so many different ambulances, and then they have to figure out their upkeep. So a low cost solution is very desirable, and that's definitely one of the potential features of MindRhythm.
Thank you. Right on.
Thanks so much, Jeff. It was great to hear, that tour de force of technology. And really, as we do come to low cost ways to distinguish ischemic from hemorrhagic stroke, there's so much potential translatable globally, because that's been a big barrier to move treatment forward, even, in hospitals all around the world. I wanted to take us back, pre-hospital again, because so much of the technology you're talking about is once the patient enters the system. And so kind of going back to those technologies about early stroke detection. And how do you envision this being accessible to the kind of general public who might not have as many of these technologies? How are we going to incorporate this to the everyday person to have early recognition so that we do get the patient into the ambulance system? I love the Las Vegas example. That really struck me. Are there ways, or is there advice that you're giving to kind of remind these inventors to really think about that group?
Yeah, some of these technologies are ones that any public governmental body for using CCTV can put in place. But other the technologies, say iPhone and iWatch, are ones that are more well-to-do people have them and are getting their benefit, and figuring out a way to make sure that we reach everybody and avoid disparities in this, especially since the people who have more strokes are the ones who can't afford these devices. But I think paradoxically, there's a way in which the development of these devices in the consumer marketplace rather than the health marketplace has been beneficial for that, because the scale and quickness with which Apple and the fitness band companies, Fitbit and Google and the others, were operating brings economies of scale that are far beyond what a small health-oriented company can do. And so even though they're starting at the top, the technologies they develop trickle down, and what is on Apple software version 8 is cooler than what's on Apple version 6, but version 6 was cool in its day and can do a lot and is much more affordable. So, but we need to make sure with subsidies and the like that these devices do get to everybody.
Thanks so much. Are there others with questions? Evelyn?
I am just blown away by this technology and the possibilities. It's a beautiful, beautiful thing that is happening. I have a question about widespread use and applicability as you're talking about trying to reduce disparities. And just a thought, are there a lot of issues with privacy? I guess, let me rephrase. So the technology in the casinos using the existing, video surveillance as a means to diagnose these strokes, could we use these technologies and expand them, let's say, to supermarkets, to shopping centers, to places where video surveillance is expected and known to people, and they're not shocked about privacy issues. And we could get them to diagnose in a larger amount of people, the workers in shopping centers, the people who attend them, schools. We don't have video surveillance in schools yet, but that might be something
Probably
that's
soon.
coming.
Yeah, absolutely. And you know, having continuous surveillance makes people uncomfortable, naturally so. You know, if you look what's happening in China and political uses of continuous surveillance, there's definitely downsides to it. So we have to be careful, but we are doing continuous surveillance in many public settings already, looking for shoplifting, looking for engineering problems or other things. And you're right, in places where people expect there to be surveillance taking place. And there, I think, using that existing technology for the good rather than the ill is something that should definitely be feasible and acceptable to the public.
Yes. And interestingly, one of my young patients who's came to me because she had a family history of early coronary disease, was celebrating her 42nd birthday in Las Vegas in a casino and had a stroke because I found this email Monday morning telling me, Dr. Stock, I don't know what's going on. My face has been droopy since I came to Las Vegas, and this happened in the casino, and all my hairs fell off on that Monday morning. And called her, and she didn't know she had a stroke. So I think for some reason, you know, she didn't get detected, and her friends thought that maybe it was alcohol related. I don't know what happened. Yeah, you know.
Yeah, and it is another issue is, speaking of alcohol, when you think about using voice assistants to identify aphasic or dysarthric speech, a far more common cause of abnormal speech is going to be alcohol intoxication. And so we have to make sure not to be over alarming with these devices. We need high specificity, but a lot of these are opt-in rather than opt-out. And also you can set it so that if it goes off, if it detects something abnormal, it first signals the person themselves, and you can say, no, I'm just drunk, don't do anything that will keep it from happening. You can also have it be set to go to a family member rather than directly to 911. So there are, I think, sufficient rails to keep it from being, EMS is understandably, especially when the Apple Watch came out, alarmed about the number of alarms that they might get, but the experience has been generally a good one so far.
Yes, no, our clinics are pretty overwhelmed with the number of AFib triggers from these Apple Watches, but we're getting more used to it and being able to, get through them pretty quickly.
All right, Hattie, maybe you'll be the last question before we switch over to the next part of our talk.
Well, first, of course, a big compliment. It's just mind-blowing how much this is evolving and how quickly. I want to know, from a cost-effective standpoint and a practicality standpoint, as someone who lost a mother and grandmother to stroke, how accessible are these new technologies? For instance, the socks, that seems like something very important, given how many strokes occur while people are sleeping. So Jeff, if you could just give us a few more details, that would be great to help spread the best practices.
Sure. Well, the simpler technologies are becoming accessible now. I'm part of a company that Dr. Rada Raichev has started down here to use the iPhone to do face group recognition, to do arm weakness recognition, and to assess speech. And there are several other companies in that space. I suspect that one or more of those will become in public use in another year or two. The wearable clothing technology is in an earlier stage of development. I think we're probably 3 to 8 years away from it being out there, but it's something that is not only going to be useful for stroke, but it will be useful for many other disease states, from being able to monitor the skin and through the skin to bodily functions and blood flow and other things that I think once the technology gets there, it will become widely adopted.
Well, that's very exciting to hear about blood flow technologies, if that might be applicable to blood pressure, the Holy Grail. Are you hearing anything on that front?
Yes, I think FDA just approved a blood pressure detection device that works with the iPhone. And there are a variety of companies that are developing devices or approaches that might work with the iWatch, ways that blood pressure can be measured without having to put a blood pressure cuff on, and people's needing to cope with that, and then can provide a readout of ambulatory blood pressure over a continuous time period to better inform physicians and patients and notify when control is needed.
So Jeff, we spend a very significant percent of our time working on blood pressure issues. And I'm wondering if you could just elaborate for 2 minutes, and then we'll turn to our next speaker on what you just said about the FDA device being approved that is compatible with the iPhone. I didn't quite catch that.
Yeah, I just read about this within the past week, and I've only glancingly looked at what was announced. So let me send you the information after I dig it up again. But I don't have a deep handle on it myself yet to be able to summarize.
Well, thank you again. This technology is really exciting, and it's been great to see your career pivot in this direction. And maybe we'll see you in the Supreme Court validating some privacy issues in the future.
Yes,
we'll see.
Hopefully not.
But yeah, but it's a valid issue, and I think that you're right. It has the power to help, but it could make people nervous. So, anyways, let's switch over. Thank you so much again. We're going to hand it back to Evelyn, my co-chair, to speak about lipids and introduce our next speaker as well. So Evelyn is she's been promoted to associate professor at UCSF and has an amazing background in both endocrinology and cardiology. And I was just telling my colleague today, Evelyn, that I've never seen someone so excited about lipids. So take it away, Dr. Stock.
Well, thank you, Nirali. It's a pleasure and an honor to introduce Kat Davis Ahmed. She is Vice President for Policy and Outreach at a foundation that is very near and dear to my heart. And the Family Heart Foundation was originally the Familial Hypercholesterolemia Foundation, and they have broken ground for advocating for patients and their families, spreading best practices, and really doing a fantastic outreach program. They developed a cascade trial or registry that we have been working on with Dr. Kane and Malloy at UCSF, learning about patients with familial hypercholesterolemia. And so, Kat, it's a pleasure to introduce you, and please show us what you brought for us to share with our Right Care advocates here.
Thank you so much. I'm just absolutely thrilled to be here, and big thanks to the Right Care Initiative for inviting me and the Family Heart Foundation, and for your very kind words. I think I might be competition for somebody who is as excited about lipids, but from a different perspective. And so it's my favorite topic, and I'm happy to talk about it tonight, and also really honored to be on a program with Dr. Malloy and Dr. Kane, who are really such incredible leaders and pioneers in the field, but also I know some of their patients, very, very beloved by their patients. And so I'm happy to start us off. My name is Kat Davis Ahmed, and I'll share my perspective from the Family Heart Foundation, and also my personal perspective. I have familial hypercholesterolemia myself, as do many members of my family, my father, his 3 brothers, my 2 sisters, and one of my 2 children. And so it is something that I'm very personally passionate about. So I will go to the next slide. The Family Heart Foundation is a nonprofit 501c3 national research and advocacy organization. We started 10 years ago and focused on familial hypercholesterolemia, and I'll talk about that in a minute. And at the end of 2021, we changed our name to broaden our mission and include elevated lipoprotein A. So I'll touch on both of those today, both inherited genetic lipid disorders with lots of synergies there, lots of similarities in terms of what the risks are, what the consequences of the disorders are, and then who do you go to see to get treated is also very similar. So we're thrilled to be able to serve a larger population. My next slide. So we address familial hypercholesterolemia and elevated lipoprotein A because they lead to the #1 killer in the world, and particularly for us at an early age, and that is heart disease. So, and that's the reason to focus on them. And for the Right Care Initiative, I'm really excited to talk about the fact that these are conditions for which we have a lot of what we need in order to improve the quality of care. And I think also really interesting to follow Dr. Saber, because he talked about how to recognize stroke and how to treat stroke and how to intervene once you are in the middle of having a stroke. I would love to talk about preventing the stroke in the first place, or preventing the heart attack in the first place. And when it comes to familial hypercholesterolemia, particularly, we have the tools to do that. Unfortunately, we are not using them to our full advantage, and people are really at undue risk. So I'd like to share just over the next maybe 10 minutes, a little bit about what we do know and what we can put into practice. And then I know you'll do a deeper dive into the science when it gets to Dr. Stock and Dr. Malloy and Dr. Kane. So familial hypercholesterolemia, if we go to the next slide. One way to look at it is to think of people who have a family history of early cardiovascular disease, high LDL cholesterol above 190 in adults or above 160 in children. Now, not all of those people are going to have monogenic genetic FH caused by one of the FH genes, but those populations will certainly have risk, and you will find the FH patients among them. And I'll share that in the next slide, the American Heart Association scientific statement on familial hypercholesterolemia gives the diagnostic elements for FH, and they are very much in line with the graphic that I just showed you. Of course, there's more detail, but those are there. There are other diagnostic criteria, and I'd love to hear later about how to think about those, but certainly red flag for family history and high LDL and personal history of early cardiovascular disease. Next slide. As many as 1 in 250 people have familial hypercholesterolemia. That means that they are born with very high LDL cholesterol that accelerates the development of cardiovascular disease. So you'll see early heart attacks, early stents and bypass, and early death for some. Next slide. There's lipoprotein A is a different genetic driver of cardiovascular disease. We don't know as much about elevated lipoprotein A as we do about familial hypercholesterolemia. One of the things we would like to do at the Family Heart Foundation is to bring what we have learned for FH, the progress that we've made, and accelerate that progress for elevated lipoprotein A, so that we don't find ourselves decades from now really struggling to find these patients and get them treated when there hopefully will be treatments. Elevated lipoprotein A affects as many as 1 in 5 people, and that is defined right now as lipoprotein A over 50 milligrams per deciliter or over 125 nanomoles per liter. And that is, if you look at the next slide, that is, you can read more about it, and there's a very comprehensive piece in again, a scientific statement from the American Heart Association out very recently. First author is Dr. Gisette Reyes-Sofer, also from Stanford, I believe. So I hope I didn't get that one wrong. But, and so the next slide brings us to why we should pay attention and look for familial hypercholesterolemia in patients. And that is that women with FH have a 30% chance of having a heart attack or a cardiac event by the age of 60. 30% chance by the age of 60, and men a 50% chance by the age of 50. And this was published in 2003. Dr. Neal was one of the authors on this. And the next slide shows us that really those numbers largely hadn't changed. This is the research that Dr. Stock referred to in the Cascade FH registry that Dr. Malloy and Dr. Kane are also our principal investigators on, with about 40 sites across the country. And we've looked, it's a longitudinal observational study of people with familial hypercholesterolemia who are diagnosed. And we see very similar cardiovascular disease rates even 10 years later. So very little progress has been made, and that's largely because most people with FH are not diagnosed. Next slide. Again, another reason to diagnose is that about 1 in 10 heart attacks in people under the age of 45 is caused by FH, and we're learning more and more that a very high LPA level poses a similar risk to FH. I believe this is in the European guidelines. Next slide. So both FH and Lp(a) are autosomal dominant genetic disorders. So once you find an individual with FH or with elevated Lp(a), it's very important to screen family members and to find out if their family members have high LDL cholesterol or high Lp(a) or both, and if there is early cardiovascular disease in the family. And I know Dr. Kane will talk later about what it might be if it's not FH and you don't find all of these signs. But this is really so important, and one of the ways that we can identify more people. So if you find one person in the family, you screen others. My family is an example. If you found, in our family, we found my uncle in 1976 at the age of 28, had one of the very early bypass surgeries. So at age 28, he required bypass surgery because he had extremely high LDL and had developed cardiovascular disease caused by familial hypercholesterolemia. And his diagnosis led to the testing and diagnosis of his 3 brothers. And then later, because my father had FH, my cholesterol was tested, and so were my sisters in high school at that time in the 1980s. So and then that followed on that I tested my children when I had children. So you find one person, you can find many people in a family, and you can prevent heart disease. So in my father's generation, there were, I think they have 6 bypass surgeries among them over the course of the last 40 years. One uncle with 3 separate bypass surgeries, the other 2 uncles with stents and heart attacks. And thankfully, they're all still here, even my father. But at the age of 57, my father had sudden cardiac death and was revived with CPR. And that is certainly, that's not an odds I want to take. Talk about Las Vegas is the chance of being revived by CPR. I'd much rather prevent the heart attack in the first place. So I've had the opportunity to be treated from a younger age, and hopefully I'll avoid that fate. Next slide. Another important reason to find FH and to diagnose it in patients early and to successfully, effectively communicate the diagnosis and what it means to people is that if 2 people who have FH have children, they have a 25% chance of having the rare form of FH, and that is homozygous FH. So I really think there's quite a spectrum here, and it's not as bifurcated as maybe it used to seem, that there are people so there's heterozygous FH with 1 gene, LDLs over 190, who respond usually quite well to drug therapy, and that's about 1 in 250 people. But with the rare form of FH inheriting 2 genes, LDL levels are much higher, over 400. But certainly I know, pediatric patients that Dr. Malloy knows this better than I do, but with LDL levels in almost 1,000 or 1,000, and very early cardiovascular disease in childhood. And thankfully, there are new therapies that are really bringing a lot of hope to this population. That's a very rare condition at 1 in 300,000. Still, 80% of people with FH are not diagnosed, and many of the people who have homozygous FH are surprisingly not diagnosed. So lots of room for improvement by following guidelines. Next slide. Again, from the Cascade FH registry, we've been able to quantify the problem and to show that in spite of guidance from the American Academy of Pediatrics and the National Heart, Lung, and Blood Institute and the American College of Cardiology and the American Heart Association guideline that asks for cholesterol screening in all children aged 9 to 11 and with a family history in children at age 2. And then again, in all children or young adults between 17 and 21. People are not diagnosed with FH on average until their mid to late 40s, and they hadn't even started statins until their mid 40s. And statins could begin in children with FH around age 8 or 10. That's what the FDA approval states. So we're missing decades of opportunity to prevent heart disease in FH. And we'll have to learn a lot more about what this all means in elevated Lp(a). We're not quite there yet. Next slide. I'm certainly not going to read this, but we presented a poster just recently at the National Lipid Association meeting in Scottsdale, Arizona. And what this poster shows is that when it comes to lipoprotein A, less than 1% of the population has even had their lipoprotein A tested. And so we really have a long way to go even in assessing people's risk when it comes to Lp(a). And so we would really like to see that improve over time. And it's really a very small number of physicians and other healthcare professionals who are ordering Lp(a) tests or lipoprotein A tests. So lots of room for improvement there in terms of testing. Next slide. If a person is diagnosed with familial hypercholesterolemia, there is now, beginning in October of 2016, an ICD-10 code for FH and for a family history of FH. And the next slide shows that in 2018, the ICD-10 committee approved codes for elevated lipoprotein A. Next slide. So I think it's very important to say that what you all do, I think, is looking at implementing best practices, right? And so guidelines, and you see the citation for the ACC/AHA cholesterol guideline in 2018 state, I think, pretty clearly what the guideline says for people who have untreated LDL over 190 with or without FH, but that certainly covers FH, or cardiovascular disease. And so in the population that the Family Heart Foundation works with, about 2/3 of our population already have cardiovascular disease because diagnosis came too late. And of course, there are all those people who don't even have a diagnosis. So the guidelines are there, and I think one could argue that they are pretty straightforward. Often the conversation talks about the people at the margins. What about if the LDL is 191? What if you treat the LDL and it's 101 or it's 71? Do you continue treatment? Or what if there are 10 comorbidities? Really, there are people out there like me. I have all of my other risk factors, and in my family, it's generally the same. No high blood pressure, no diabetes, no smoking, no all the the other risk factors, just LDL levels in the 300s. My untreated LDL is 360, and similar for my sisters and my father and my uncles. So in those cases, it could be pretty simple. We're all considered high risk. No risk calculator is needed. It doesn't apply to people with LDLs over 190. The first line of treatment is statins. They are generic and highly researched. There are treatment goals for these populations stated in the guideline, and one could argue maybe they should be lower, but most people are not even reaching these goals. So we could start there, and then recommendations for the pediatric population as well. So if we're talking about implementing what we know, we have diagnostics, we know the risk, we have guidelines, and we have treatments. So our hope is that we do a better job of implementing all of those and helping more people. So the next slide. For Lp(a), there is potentially lipoprotein apheresis, but there are no drug treatments for elevated Lp(a). However, lowering all other risk factors, including LDL, does show benefit for people with high elevated Lp(a). And again, lots more to learn about this population. We've had treatments that have developed over time. We have all these treatments more and more in the last several years that can all lower LDL. Next slide. However, again, back to the research from the Cascade FH registry, we find that even for people with cardiovascular disease and FH, only 22% of those people are reaching their guideline recommended LDL goal of below 70 milligrams per deciliter. And when they do, they are on 3 to 6 lipid lowering therapies. So that means going beyond statins, adding ezetimibe, adding a PCSK9 inhibitor, adding something else. Those are the people who are reaching their LDL goals. Next slide. So I'll just conclude with saying that, I hope that I've made a case for finding and managing familial hypercholesterolemia, testing for high Lp(a), communicating this diagnosis to the individual and to their family members, or helping them to do that. And I'll say that the Family Heart Foundation has resources to help physicians and nurse practitioners and genetic counselors and other healthcare professionals and patients to find their way to the best information and to understand better what this diagnosis and what the opportunity for treatment is. So we have our website, the Family Heart website. Next slide. We have a care navigation center there where the #1 question is, I need help finding a specialist. So if you are a specialist, a lipid specialist, please visit our website and add yourself to the map. People also ask about their treatment options. They want to understand those better. We have great resources for that. Next slide. We have lots of webinars. A lot of our patient population is extremely sophisticated. So I would say these webinars are certainly patient facing, but they are also very much at the level of the healthcare professional as well. And so I recommend you check those webinars out. Next slide. We have educational tools and resources for patients you can print or share digitally. Lots of great explainers. And the next slide is inviting you to visit our, it's best on our YouTube channel, our Family Heart Global Summit recorded videos from our 2020-2021 summit. And this is a scientific meeting that we hold usually every year. We did not during COVID. We hope to start again in 2023. But this is a healthcare provider science researcher facing program. Dr. Hagley gave the opening to this series in the last year. So I really recommend that, and the easiest way to see that is on our YouTube channel. Next slide. Thank you. It's really been a pleasure and I really appreciate it. Thanks so much.
For the excellent presentation and for joining us from the East Coast this late at night. I think we're going to defer to Eveline Stock, who is also an expert in this area. Many of you know her, and she's a molecular cardiologist who's also trained in endocrinology, and she is going to be leading this next section for us. Many of you already know her. She's our co-chair of our Silicon Valley chapter. And she is, I think she has had a promotion since we created the slide. She's an associate professor of cardiology at the University of California, San Francisco, and an amazing gift to the Right Care Initiative, amazing part of the Right Care Initiative family. And with that, Eveline, I'm going to turn it over to you. Next slide, please.
Thank you, Hattie. I am honored to be part of Right Care and also very much appreciative of Kat Davis Ahmed and her team. Driving that Family Heart Foundation is quite a gift to the community, gift to the physicians. So thank you for that. I very frequently refer my patients, and I can't tell you how much it helps the clinicians to be able to have these resources for patients. Many times what patients face is that you diagnose the elevated LPA and elevated cholesterol, they go to their family members, and I've had a number of patients where their family physicians refuse to request an Lp(a) because they don't know about it or don't know that it's important. So I think these knowledge gaps are huge still. As you pointed out, only 20% of people are diagnosed, and these gaps need to narrow. So I think foundations like yours and getting people the knowledge and the access to these is very important. We are definitely needing to have interfaces with our electronic medical records so that these patients can be screened and identified without falling through the loops. Does the Family Heart Foundation have any of these resources, or are you plugged into any medical centers that have these resources?
Yeah, thanks so much for the question. I think there are a lot of really interesting initiatives out there at health systems where they're using the EHR and looking for people with LDLs over 190 or other, using other rules to find people who need to be flagged. At the Family Heart Foundation, over the past, I think it's at least 5 years, we have developed a machine learning model, like an algorithm, to recognize likely FH in data sets. So we can do that. We have a large national data set on which we built this machine learning model of over 300 million people in the healthcare system. And then the model also works on the EHR data set. So we work with 5 or 6 different health systems where we search their EHR data in a limited data set, of course, all de-identified and all that good stuff. And then we can return a report of who would be flagged for probable FH so that we can narrow down. If you look for people with LDLs over 190, you get a very large group of people, and it's hard in a stressed healthcare system that we all experience to do the outreach to all those people. So we narrow it down so that every person that is flagged has about an 80% chance of the expert agreeing with the flag. So that's published in Nature Digital Health and in Lancet Digital Medicine. And so we are returning results, reaching out to people and identifying people who are today being diagnosed with FH who were undiagnosed previously, thanks to this machine learning effort. So that's happening at several different healthcare systems today.
So if I understand correctly, you are returning the results to the patients and they're providing them with the information.
We are working with health systems in a collaborative learning network, where we work, the Family Heart Foundation works with each health system, and then we work as a group, as a collaborative learning network. So, half the battle is flagging the person, saying, okay, this person looks like, the machine learning says, looks like they have FH, but then you all work in health systems, you know how hard it is. Then what do you do? Do you do a flag in the EHR? Does anybody pay attention to the pop-ups? Everybody has flag fatigue. What words do you use when you pick up the phone and you call them, or you send them a My Chart message? Or how do you reach the patient? How do you convince them to come in? And then how do you communicate, if they have FH, how do you effectively communicate the diagnosis in such a way that they take action on the information? And to your point about the people, their primary care physicians not wanting to run the Lp(a) test, we also hear from people who say, I'm really worried about this LDL of 250, and my specialist told me I had FH and I need to be tested, or my kids need to be tested. And their primary care, honestly, sometimes pushes back. Or sometimes the pharmacy pushes back and says, what are you doing on these drugs? So I think we help to play a role to improve the health communication and bolster the diagnosis. And I'm glad to hear you say making it easier for the physician who's made the diagnosis.
Yes. Any other questions?
I think it will spark a lot of conversation when you go through your molecular cardiology slides, Dr. Stock, which are going to be, I think, jointly presented by your colleagues at UCSF, including Dr. Kane.
Yes, so thank you, Hattie. I am honored to and very happy to have Dr. John Kane and Dr. Mary Malloy with us today at the Right Care Initiative. This is a special treat that we're able to have this panel today. Dr. John Kane is extremely well known in the field of lipoprotein research. He is an innovator, a physician scientist, and he has made significant and outstanding contributions to the field. In his early career, he developed a method where using non-denaturing immunoabsorption of lipoproteins, that's a lot of words, but basically he developed a method where you could get natural HDL that was not spun down, was not disturbed, and made this completely changed the field of how we understand the development of coronary disease, and frankly, the plaque, how does the plaque form? The molecular insights are enormous. By having denatured HDL, you're able to isolate the lipoproteins and study them in their natural form and not get fragments of molecules. And so he also discovered B48, which is the lipoprotein in chylomicrons, and so on and so forth. When I interviewed in his lab, when I was coming from Massachusetts General to do a cardiology fellowship at UCSF, I just said, I want to work with him and learn as much as I can. And it's been a great, great journey. So I also, well, Dr. Kane is also the director of the Adult Lipid Clinic and professor of medicine at UCSF. Dr. Mary Malloy is also a giant in the field of lipid disorders. She is consultant to, I would say, every lipid clinic in the West Coast that has pediatric disorders. And she's the director of the pediatric lipid clinic at UCSF and co-director of the adult lipid clinic. She has been working in also advancing the field. One of my most memorable, findings with Dr. Mary Malloy is this patient who walked into Dr. Malloy's clinic with giant xanthomas on his elbows and ears, and Dr. Malloy grabbed me from my clinic and brought me to see this patient, and a whole series of molecular investigations ensued, and Dr. Malloy discovered the man with no ApoE that had never been described, a deletion in the ApoE gene, where that provided insights to possibly develop therapies to knock out ApoE. ApoE4, as people might know, is a risk factor for Alzheimer's disease, and people were very afraid to knock out this gene because they didn't know what it could do to people. But this man walked into her clinic and had this wonderful person see him, and this discovery of ApoE deletion. So I want to present a few slides. We are going to be doing a brief molecular lens on targeted cardiovascular prevention. What do we do, as Kat Davis-Ahmed was saying, so that we can prevent disease in time, because we know that if we diagnose these patients, especially FH patients, before age 40, we have a much better possibility of preventing this 2/3 who already have heart disease by the time you diagnose them. And how do we go about getting people on the right treatments and personalizing their care so that we can be effective, reduce side effects, and improve outcomes? Let's see the next slide. This slide shows how atherosclerotic cardiovascular disease, that is in the center there, is caused by divergent but cooperative pathways. I'm going to use this slide to bring in Dr. Kane and Dr. Malloy at various points so that we can have a very, collaborative discussion about these pathways and how the molecular basis of atherosclerotic cardiovascular disease provides insights into diagnosing these patients and providing therapies. For example, we can start with hypercholesterolemia on the upper left. You see a number of genes that cause this disorder, starting with the LDL receptor, right? Over 800 mutations known to man, and ApoB mutations, PCSK9 mutations that led to the development of PCSK9 receptor antagonists. We have lipoprotein clearance defects with ApoE, genetic disorders where you have the ApoE disorders that are the most severe, causing increases or decreases in ApoE, also involved in elevated LPA. Can you still hear me? Can you still hear me?
Yes.
We can hear you, but your sound quality is starting to be a little iffy. I wonder if we should bring in Dr. Kane and Dr. Malloy to speak a little bit, since your audio is getting
Thank you.
a
Yes.
little distorted, Eveline.
Yes, thank you. John, would you give us, please, your insights into how you approach a patient with elevated cholesterol or elevated LPA in the clinic, and what are your thoughts about molecular insights?
Please unmute, John. Dr. Kane, please unmute your, let's see if I can do that for you.
I got it now. Can you hear me?
Yes,
All right,
thank you.
Well, I think that, the emphasis has already started out here quite appropriately directed at the molecular aspects of coronary disease. And before I'm done, I want to mention some new dimensions that are actually appearing that may add even more insight for individual patients as we go along. But clearly, there are different lipoprotein patterns or phenotypes. And the first task is to ascertain which disorder of lipoproteins we're dealing with. Sometimes it's a multiple disorder. And because the treatment for a given phenotype is individual, and one treatment doesn't fit all by any means. And so practitioners, this is not a rare disease. And therefore, I think that all cardiologists, internists, primary physicians ought to understand the fundamentals of this, because this is the leading cause of death in the United States. So we're not talking about a disease that affects one person in 5,000 or something like that. So the world started out being conscious first of hypercholesterolemia, but it became obvious as things progressed that hypertriglyceridemia was also serious. And there were doctors when Mary and I were starting out, were waving hands and saying, oh, hypertriglyceride doesn't matter. Well, that's not true at all. And it was actually when, with some other investigators at UC, that we actually looked into plaques from coronary arteries and other arteries, and found the hypertriglyceridemic particles were there in the plaques. So how could you say it didn't matter? And so now there's been a progressive gain of interest in this field, and there are many, many other pathways involved, other proteins, other disorders, and so on that contribute to this. But this has an equal importance in the causation of coronary vascular and cerebrovascular disease. Certainly, it's abetted by diabetes. We know now that inflammation is a result of type 2 diabetes, and that inflammation is directly involved with the lipoprotein particles in the artery wall. So we have to think of this in a conjoint way, and certainly obesity. And this now reaches to fatty liver, because a number of people who have coronary artery disease and dyslipidemia have fatty liver, and it's contributing to the disorder of lipoproteins in blood. So chronic inflammation, we mentioned, certainly thrombosis is greatly impacted by inflammation and dyslipidemia. So we have to think of this collectively. Certainly the endothelium becomes a very important part of this. And because you've mentioned LPA, which is an important cause of coronary vascular disease, LPA levels are impacted materially by homocysteine. This is a chemical that occurs in a whole lot of people, higher in level, almost everybody. But in people who have a very high level of homocysteine, they have trouble getting rid of LPA. And so it contributes to thrombosis caused by LPA. So we really have to think in these interactive ways. But I'm just to show that I think we're looking into a future where we're going to be able to be much more informed and much more able to intervene, because there are other dimensions of risk. One of these is other lipids. There are almost 400 different lipid species in human plasma, cerebrosides and all kinds of dyslipidemias, individual molecular species of lipids. We have a colleague now who is able to measure all 400. And so we are going to be able to, I think, be telling the world in the upcoming months and years about the damage that can be exerted by these rare lipids, which can be in tremendous excess. And just to illustrate the importance of LPA, you pointed out very ably the distribution of high and low levels, but we have a young college woman who has an LPA level of 2,400 nanomoles. Well, we can only start to appreciate what could go wrong in the vasculature of this young lady. So lipids. Okay, number two, genomics. There are a number of other loci appearing for genomic control of vascular disease and others, cerebral vascular disease, cerebral lipid metabolism leading to disorders, so dementia and so on. There are many dimensions to this thing that we're just stepping into, and so the genomics are very important. We are now doing whole genomic analysis on people with new and varied kinds of dyslipidemia. And so this is an area that's going to move forward. We're going to be very much better informed going forward. And it's a time when we can actually begin to change the expression of genes. And so CRISPR intervention and so on, we're looking into new dimensions here. But lastly, I'd like to also mention that we have discovered that in plasma there are about 45 molecular species of HDL that contain over 100 proteins. And just to show how they're entering into other dimensions, we found one species that we have published that complexes endotoxins. It contains the endotoxin binding protein and helps to protect against endotoxin shock. And this has been demonstrated recently to be a point for intervention to protect children with endotoxemia and shock. So the dimensions here that are opening up to us are numerous and very exciting, and certainly hold what looks like a real promise of interventions, clearly in vascular disease, but also in related disorders like endotoxemia and diabetes and many other dimensions. So we have a great deal of enthusiasm about where things can go from now, and it's going to be very molecular. Thank you.
So thank you, John. And can we have the next slide, please? So here is the metabolic pathway explaining severe, or a pathway that we can use to show the pathways that lead to severe hypertriglyceridemic phenotypes. And when John and Mary taught me how to, look at these dyslipidemias, one of the things that they emphasized was to distinguish these two very different types of hypertriglyceridemia, those that are due to defects in lipolysis that you see there, blood vessel defective lipolysis, in which the patient is unable to process these triglycerides that are coming in the chylomicrons because of defective genes that don't allow lipolysis to happen. The regular ones, the frequent ones are called the gang of 5, lipoprotein lipase, ApoC2, ApoA5, LMF1, and the binding anchoring protein GPI, HBPI1. Newer ones like angiopoietin like 3 and 4. The way to distinguish these from overproduction of VLDL, where the liver puts out too much VLDL and you have hypertriglyceridemias, is by checking the LDL cholesterol. When you have a defect in lipolysis, the chylomicron cannot process and transfer their lipids to the liver and produce the LDL, and you have low LDL levels. So Mary, I want to ask you, when you see patients with elevated cholesterol, what is your regular workup that you do, and can you give us some insights into how you think about it from a molecular perspective?
Yeah, well, I think one of the mistakes that sometimes is made is that people, I don't know whether they're saving money or what happens, but they only order a cholesterol level, and the cholesterol level might be 350. So they pull out the statin and give 80 milligrams of atorvastatin or something, and it's not really helping things very much. And the reason is that when triglycerides are very high, the total cholesterol is looking at the cholesterol that's being carried in VLDL predominantly at that point, and chylomicrons are competing with VLDL, as your picture there shows, for the lipoprotein lipase clearance mechanism for the triglycerides. But the VLDL goes on to form LDL as the triglyceride levels are reduced, assuming that everything is intact in terms of getting the intermediate density lipoproteins, which are the step after VLDL, then it becomes the IDL. And if their ApoE complement is normal, then that those particles, some of them, about 50% of them, will probably go on to form LDL, which is the daughter particle of the VLDL. And so you can get kind of mixed up thinking about high cholesterol levels, where, as John mentioned earlier, it's not necessarily appropriate to give a statin to everybody just because the total cholesterol is high. You have to figure out what's going on. So in answer to the question, I think the first thing you need to do, obviously, is just do a regular, excuse me, a regular lipid panel, so that you can see, and I always like to get that fasting. And in fact, as I'm reviewing referrals to our clinic, I order a fasting routine lipid panel that will give me the LDL and HDL, as well as total cholesterol and triglycerides. And by the way, we always routinely measure Lp(a), unless referral information lets us know that this has already been done. And to congratulate the primary care doctors in the area, I must say that we're seeing more patients coming into our clinic with the Lp(a) having been measured. And I think that everybody's agreeing these days that the measurement that ends up with nanomoles per liter is preferable to the milligram per deciliter method. Anyway, so we look at that picture, and sometimes we will see significantly elevated triglycerides, but they're still low enough, below about 200-300, so that you can really know what the LDL is by calculation. And then that may lead you off in different directions as well. But I think the basic look is pretty fundamental and pretty simple, actually. That we don't often use the fancy breakdowns because if the LDL is elevated, then there's going to be an increase in the number of particles and things like that. And if they say that the thing is pattern A versus pattern B implying that the triglycerides are also elevated, but pattern A, which is supposed to be the preferred pattern, is the pattern we see in familial hypercholesterolemia patients. So those patients have pattern A, and they certainly are not happy campers in terms of what can happen with their problem when it's untreated. So in terms of younger patients, when we have families available, and particularly in the pediatric age group and teenagers and many young adults now, I always ask them to have both parents, if they're available, give us their lipid panel results. And this is very helpful in terms of sorting out conditions. And the other thing is that we've got to remember that a lot of people have more than one lipoprotein risk factor. And those obviously include the elevated triglycerides, elevated LDL cholesterol, low HDL, and elevated Lp(a). And then we go on and look globally at the non-lipoprotein risk factors, both in terms of finding out what this patient really has. Do they have a genetic basis for these high triglycerides? And then on top of that, they're obese and insulin resistant, and eating too much fat, et cetera, because the start of all of this, barring the patients that you see in your cardiology practice, where if they have any evidence of already of disease and everything, you're not going to ask them to try a diet and exercise for the next 3 months and see them again. You're going to start them on their statin or whatever it is they need, and then go back and pick up on the lifestyle things. But in the younger patients, we always do the diet and the exercise first, and the diet is related to the diagnosis. So that's all sort of basic.
Mhm. So when would you recommend to order the first LP(a) for pediatric patients and their first cholesterol if they come from a family with history of heart attacks or strokes in first-degree relatives?
Yeah, well, if I have the panels on both parents and there is a history of premature stroke or heart disease, except I don't like the word premature. I think at any age it can actually be important depending on what other risk factors they have had for that. So anyway, yeah, we otherwise will measure everything in the child from the beginning. And if they have high cholesterol, high LDL cholesterol, and it looks like a clinical diagnosis of FH, it's very important to measure the LPA because it adds such risk. And it, for me, is one of the big determinants in how young I'm really going to start statin therapy on that FH child, if they also have a high LPA. And sometimes we have one parent who has provided a lipid panel, and then the child is screened, and when I'm doing the LPA on the child, I find it's elevated. Then I go back to the mom, and then we hunt down the father and find out, where this is coming from. Because if the child has a gene from each parent, completely different gene for a different disease from each parent, that is a risk factor for heart disease and stroke, then you can't just look at one parent and say, oh, she's already 35 and she's fine, so why am I worrying about this 6-year-old? So the more we can learn about both parents and siblings in a kindred is going to be really helpful, not only in terms of diagnosis, but in terms of management.
Excellent. So the guidelines recommend to obtain an LPA at age 2, after age 2. I don't think we see that in our pediatric practitioners being applied.
No, the only group in pediatrics at UCSF that I'm aware of that now is routinely measuring LP(a) are the neurologists in the stroke clinic. And so then they send this 2-year-old to me with LP(a). They've ruled out, they've done a fantastic job of looking at all of the thrombi genes and conditions, and the LPA being very high may be the salient risk factor for that child's stroke. And unfortunately, at the moment, we don't have a lot to do about that, except to give them, they're already on anti-thrombotic, so we don't use the aspirin in them like we do in the adults. But we're hoping, as you well know, and you were involved with, it won't be too long. I'm guessing 2 years. I don't know, maybe that's not optimistic enough before we get the a antisense so that we can really reduce the levels in these patients. It's going to be a godsend.
Yes, yes. So yeah, thank you for bringing that up, Mary. So now we have these powerful antisense silencing RNAs or antisense oligonucleotides that lower LPA effectively much more than 50%, closer to 90%, independent of lowering LDL. So we're able to determine if and how they affect cardiovascular disease progression and stroke. And one of the things that has really, really impacted me that you are receiving these consultations or these referrals for very young people that present with stroke. It apparently is a higher risk, or at least it's what we have seen for stroke in the young population and the teenagers or people who come in with stroke and no other risk factors, the LPA. We've seen a couple of cases. Would you like to comment on that, Mary?
Yeah, well, other than just to agree about the importance of measuring and doing what we can. I mean, there are data that tell us that right now, before we get these other, agents, that aspirin does really help. It actually affects the molecular structure of fibrin in the clot and makes it easier to lyse. But just 81 milligrams of aspirin is effective in that way. And the other thing is to keep the LDL level, I think, well below 100. The data say 100 or below. And I say, well below 100, just because we don't know. I mean, we don't have enough data to really tell us about that. And so, so many young people have elevated cholesterol that isn't in the FH range. Although I must say, and I know that Kat is well aware of this one, that you can genetically diagnose FH in one of its many forms, genetic forms, and not have an LDL level over 160, that we frequently see them in children at 140, 150, 130. I just saw a child very recently whose LDL level was the lowest I've seen with genetically proven FH at 110. So it's in the family, and you make the diagnosis that way, and you make it genetically. But yeah, it's something that you would treat anyway. If their LPA was high, you would want to reduce that level.
Right, absolutely. And the other forms that we see manifesting later when people either start eating more or increasing their body mass are the familial combined hyperlipidemias that initially.
Yes, that's true. And we have families. I think John has the oldest one, but oldest family kindred that we've looked at through the years, where one parent has contributed heterozygous FH, and the other parent has contributed what we always have called familial combined hyperlipidemia. These days, some people just call it combined hyperlipidemia, but I like the FCH because it does run in families so often. And that increases risk, no question. Remember the family we had where the mom had FH and the dad had FCH, and one girl had FH and one had FCH, and one unfortunate young lady, the third sister, had them both. And she had a heart attack in her very early 20s. I think it was 22 or something like that when we first found the family. So, and if they have, again, the LPA plus FH or a high LPA, I have a patient with a very high LPA in the six times normal range, 6 to 7 times normal, and also has an extremely low HDL with one of the newer genetic reasons for people having low HDL. And she presented actually with not a stroke, but she had an MI, and she's only 32, I think. So all these combinations exist.
Yes. So thinking about diseases that mimic FH, would any of you want to comment on how you go about ruling out the cytosterolemias or the cholesterol ester storage diseases? How do you think about that? And since they have specific treatments,
you want to talk about that? But before he answers that question, I think well, never mind, go ahead.
Well, anyway, there are probably other causes that we don't even know about yet, but certainly phytosterolemia is where plant sterols, which are very structurally close to cholesterol, accumulate because the one of a pair of gene products whose duty it is to prevent the reabsorption of sterols are not functioning. And so you can get very high levels of plant sterol, especially if there's a diet that has a lot of plant sterols in it. And these patients develop xanthomata, deposits in the cornea, and certainly early coronary disease. And so usually you suspect these if it's behaving like a recessive disorder. And it's been our experience that we've seen more of these in people from certain populations like the Indian subcontinent. But there is an assay for phytosterols that you can order. And it's a single test and it's very informative. The other that you mentioned, very important, cholesterol ester storage disease, where patients lack the enzyme that can take cholesterol ester apart, separate a fatty acid from the cholesterol molecule. And those patients look like FH patients. But the first thing is that if you have two parents where you don't have obvious hypercholesterolemia, this is number one. And this is a test that can be done on the blood as well. You don't want to make that mistake. As I mentioned previously, giving a statin to somebody who has cholesterol ester storage disease really hastens the onset of the disease, the serious vascular consequences. So, and then obviously the secondaries like nephrosis and hypothyroidism and a host of other disorders. So these have to be entertained, and some can be eliminated just by appropriate history, and some of them have to be tested for.
So I want to open the discussion to, in the interest of time, and give other of the participants and panelists a chance to ask questions. We have one from Matthew Ito. I think this was directed to Kat Davis, Ahmed, and the whole panel as well. As part of the problem of underdiagnosis and treatment of FH is that LDL cholesterol has been removed as a quality measure by NCQA. And Matt asks if the Right Care Initiative made an attempt to get LDL cholesterol back on the radar. We have not. Anybody know anything about this?
I should say that I lobbied really hard for them not to remove that, because what you see in the graph behind me there was driving a community's LDL to less than 100, blood pressure less than 140/90, and A1C less than 8. And it had a huge, fast impact, particularly for women where there was so little awareness. So Matt, thank you for the question. Let's talk about that further offline. I'd love to have bring Dr. Joe Skye into the conversation, cardiologist from Travis Air Force Base and one of our co-leaders.
Good afternoon, everyone. Wonderful presentations. My question is this: for those of us cardiologists that treat adult patients with lipid disorders, I'm interested in hearing what the panel thinks. In addition to the wonderful presentation on the cellular aspects and the serum aspects of these diseases, would there be a complementary role for coronary calcium in screening the general population? And if so, at what age would you recommend this? I'm especially interested in Dr. Kane's opinion.
Well, it's certainly very useful. And I think we're not anywhere beyond seeing new interventions, new studies that are informative about because calcium and cellular inflammation are not necessarily the same thing. And we see some patients who have very active vasculitis and no calcium, and patients who will be quite the other way.
Soft plaques.
So soft versus calcific plaques. I think we have a lot to learn there. And there may be some small molecules we'll find in plasma that are very informative too. So,
but overall, and Evelyn should comment on this because she's a cardiologist, but it is a way of looking at structural disease that is becoming more and more common. When it first started a number of years ago, you may remember, somebody at UCSF, and I'm blocking on his name right now, started doing them, and it caught fire. Everybody was getting a calcium scan, and then people started saying, well, you know, there's some radiation. Maybe these people are too young. Maybe we're not seeing them. Maybe if they're under 40 or under 50 for women, maybe it's just radiation without a purpose. And it kind of went away, but now it's back, and now it's back big time because we are finding disease. And I think that I personally have done these on a series of young women who come to me saying, okay, I have FH and I'm getting married, I want to plan my family, I'm going to have some kids. And very recently, that's helped a little by a bunch of people saying it's okay to give statins to pregnant women. I'm not in that group yet right now. But anyway, we do see, I have seen calcium scores over 0 in these young women. And what we do is we say, okay, how long is it going to be before you want to get pregnant? And then we find this on the calcium scan, and I just knock the bottom out of their LDL levels for a year or 2 years, maybe. And that buys them time to be pregnant and nurse a baby and not, you know, be taking medication. So now that we're being told it's okay to give a statin to a pregnant person, and by the way, I still believe the data that shows that there can be fetal anomalies in the first trimester if you give a statin, and probably beyond the first trimester, it probably is okay. But anyway, the calcium scans in the very young people are going to be negative by and large. But Evelyn, what is the cardiology dogma at this point?
Well, we recently put out a statement for women cardiovascular prevention with Dr. Noelle Berry-Mertz, who is expert in the field of women's cardiovascular health. And the recommendation that we came up with is to do a coronary calcium score 10 years before the family history of the first family member. So that way.
But how do you figure that out when the one guy was a 2-pack a day smoker and had a big belly, and in other words, had other risk factors? Does that make sense completely?
Well, not if they have that such great other risk factors. I think that's a good point, right? And we always ask when we're making the family history, did that heart attack occur in the setting of, you know, obesity or smoking or some other diabetes or some other cardiovascular disease? So if there's no additional, I would say, reversible risk factors, that's a great point, right?
Well, I know that I've sent a number of patients to you, and you have gotten the calcium scans, and they've been very helpful in terms of planning the longer term management of the patient and how aggressive I'm going to get in their lipid lowering.
Right. There's a number of prospective studies, including Cardia, showing that the cumulative effects of elevated LDL and how LDL elevations, depending on how high the level is and for how long it remains untreated, you're going to have a higher number of people have higher coronary calcium scores earlier and more pronounced extensive coronary disease levels. So Cardia did these prospective studies and found that 1 in 20 women have elevated calcium scores by age 45, I think. And in people with FH, these curves become very steep.
Yeah.
So
right.
you
In fact,
have
yeah, that they're kind of easy for that reason, but yeah.
right, right. And then when you have those people with very, very low LDLs, they cruise along. And the idea would be to capture these people early so they can cruise along those, low LDL, never have a problem.
Yeah, yeah.
And
Well, I think that the data that showed that it's the time averaged LDL that over a lifetime that is really one of the best, if not the best, indicator of risk for future MI and stroke. And that's, that's the way I like to sell it to the younger patients, that they do need treatment. I just saw an 80-year-old woman who has FH, and all her life she's had LDL levels in the 190 to 220 range. And she's seen it, she saw Tom Ports, Dr. Ports, cardiologist at our place, and she's free of disease, absolutely free of disease. And I'm still trying to tell her it's never too late to lower this LDL. She's not going to do it. And I asked her if she was Danish, because our family that John and I always talk about in the East Bay that have FH, and the grand matriarch was around 90 when we first saw her. And her untreated LDL was in the 400 range, which sometimes means HoFH, but she didn't have that. But 2 of her little guys her sons were in our angiogram trial years ago. One was 60 and one was 63. And one did everything right, the other did everything wrong. I diagnosed his hypertension for the first time. They all had the high LDL levels. Nobody in that family has coronary disease or stroke. And the grandma lived, finally, I guess when she was about 97, 98, she was still driving her car, and she had to park too far away from where she was going. So she had to walk quickly because she was late, and she got a little pressure in her chest. And so we said, go to the emergency room. You had this thing. Long story short, she had a stent and 1 lesion in her LAD. And then she went on and did everything. And finally, when she was 104, 105, something like that, she finally went to sleep. And nobody did a post, so we don't know what her arteries look like. But so FH can be both ways. It can be very low levels, it can be very high levels, it can be mega disease or not. And I'm a believer that the LPA factor is a big distinguishing thing between who has a problem and who doesn't have a problem.
Mm-hmm. Another factor that is unrecognized and that you both have made significant contributions to is the understanding of reverse cholesterol transport and how that contributes. If you have good reverse cholesterol transport from the artery wall, you're able to better manage these loads of LDL coming into your artery, and you're able to sweep them out and prevent disease. Whereas if that's compromised, you're going to develop possibly heart disease and significant plaque, even with normal cholesterol levels, right?
Sure.
So
And there's so many, as John said, there's a bunch of genetic factors, all kinds of factors that we have no idea about right now, that are just being measured.
Patty, any more questions? I mean, we could keep talking and I have, but I think
I think we're running out of time. I did see that Kat Davis had a question. Kat, would you like to unmute yourself and ask the final question, and then we'll just give it a wrap and see everybody back here in the future to continue this really important discussion.
Thank you. I know we're over time, but I wanted to make 2 points. One is just to be careful about the calcium scoring. I think you did talk about this, but just for everybody to remember that often people use it as a 0 score, even if their LDL is sky high, as an argument for not starting the statin treatment. So it's something that we hear from people with FH all the time, and they have a false sense of security from a 0. And they often get it too young and nobody explains to them. They don't have the benefit of seeing Dr. Malloy or Dr. Kane or Dr. Stock or Dr. Sky. So I always feel it's very important to say that, because I think a lot of people are not treating because, and my argument with them is I say, well, if you had a chest x-ray and you're a smoker and you don't have any signs of emphysema or lung cancer, are you going to keep smoking until you see the signs? And that's like saying I'm going to leave my LDL at 250 or 300 until I have a positive calcium score. So that would be my from listening to thousands of patients over the last 10 years. That is one of my points. And then the other, I think, it's so fascinating to me, and we definitely hear from people who are misdiagnosed with FH, and honestly, having a child diagnosed with homozygous FH who then instead has cytosterolaemia, actually can be a big relief. So it's so important to, for many, many reasons, to have the right diagnosis. But I would also emphasize that FH is often just not that complicated. And I think the like looking for other causes and all of that sometimes distracts from what can be a pretty straightforward diagnosis and treatment plan.
So on that note of being straightforward, I think that's one of the reasons we still have such a high level of death at early ages from heart attacks and strokes. And that is, we don't use a standard screening strategy to make sure that people don't have an LDL over 100. It is, if we simplify. Now, what we've done today is fairly complicated. We've learned about some very complicated things. But in order to make progress in this area, I think that we need to have some simple rules, and we need to teach them to primary care. So one of the things that we'd like to see happen is a requirement that primary care has to learn the American Heart Association ACC guidelines, for instance, required continuing medical education with testing to ensure that they know that what the regular schedule is. And I would just say the lives of primary care physicians are very complicated. And like many other patients, I've been in the situation where for years I've been trying to learn and request the tests that I need based on my family history. But I can tell you, even very highly regarded internal medicine doctors really don't have a lot of information. And actually, one of our leaders that's on the phone with us here or on the video who hasn't weighed in was telling me he was golfing with a cardiologist recently who didn't know how to use the heart CT scan, didn't know what to do with the score. It's, to me, yes, I agree with you, Kat, that the FH patients might be that 1%, the less than 1% of people who within 10 years of having a heart CT scan with a 0. So if you have a 0 in the next 10 years, fewer than 1% of those people are going to have an event. But if you know you have FH, I don't see the point of, I mean, these things are not mutually exclusive. They need to be taken into account together. And like you, I'm not a physician, but I believe that the more the cardiologists and the endocrinologists and the people who know all these details make it super simple for primary care doctors by creating shared decision-making tools that would have a clinical pathway that gives specific advice to the primary care level, we're going to catch the large majority of these patients. So on that note, I would just say, I really appreciate that we're in this together. There's a lot we can do together. And we'd love to see you back with us after we take our brief sabbatical in July. We're not going to have any more university best practices until August 8th. And I'm looking forward to having many of you back with us at that time. Meanwhile, enjoy your summer. Thank you so much to our brilliant panelists, speakers, and leaders of the Right Care Initiative. I just couldn't thank you more for your devotion to improving clinical outcomes. Thank you so much.
Thank you. Great program.
Bye. Thank you.
Thank